Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. The feature presentation is Acute Coronary Syndrome Special Considerations in patients with normal EKG and questionable troponin levels or borderline troponin levels, ongoing chest pain, and non-PCI facility when you're dealing with STEMI patients. Before I go any further, I would like to tell you I have put together a cardiology rotation manual consisting of 250 pages. I'll tell you at the end of the presentation how you can get a free copy of this cardiology rotation manual. So let us continue with the feature presentation. The feature presentation, that is acute coronary syndrome special circumstances, is based on this 2021 ACC AHA ASC update on guidelines for evaluation and diagnosis of chest pain. And here's the reference. I don't know if you can follow my arrow. Here's the reference. I would strongly suggest you download this article and get familiar with the article. It doesn't matter whether you're a primary care doctor, a cardiologist, an echocardiographer, a nuclear cardiologist, or an interventional cardiologist. It applies to every one of us because more than 95% of the patients we see in cardiology practice is related to coronary artery disease, and acute coronary syndrome is one of the most important ones which we face in an acute situation, intermediate situation, and on a chronic basis. So let's learn something more about this. The essence of this article was summed up in 10 points, which is characterized by this acronym chest pains. Basically, what it relates is chest pain. Chest pain is something that we need to really expand it to a point where you're not only concerned about a classic chest pain, but anything that patients feels inside the chest area or the upper abdomen that is uncharacteristic or that is suggestive of a cardiac problem, we need to take into consideration. Even symptoms like fatigue, shortness of breath, all of these things need to be taken into the context of the patient's evaluation. Then we have the high sensitivity troponin, which is the standard for diagnosing myocardial injury or damage, and no more CKMBs are recommended in evaluating patients with acute coronary syndrome. Early care, that goes without saying, and shared decision making. Shared decision making means it involves doctors, nurses, intensive care units, cath lab, and if you're a facility where you cannot do PCI, you're coordinating with a facility that does PCI. So it involves a lot more people than just the emergency room physician dealing with an acute coronary syndrome. Testing. Routine testing is not needed in patients with low risk for coronary artery disease. And this is where we are talking about how do we risk stratify patients when they come to the emergency room with the first onset of chest pain or recurrent chest pains, or who has no history of coronary artery disease versus a person who has history of coronary artery disease. Then we have clinical pathways which are clearly defined, not only in this article but in many other guideline articles. So I would strongly recommend you follow those guidelines and pathways, and every institution may have their own pathway for dealing with acute coronary syndrome, and it is something that we need to get extremely familiar with. Then accompanying symptoms, just like I was talking about chest pain, when patients present with accompanying symptoms of shortness of breath, weakness, fatigue, dizziness, or sweating, all of these things need to be taken into account. Sometimes the pain could be felt in the upper right quadrant of the abdomen, and it may be mistaken for a gallbladder attack, where in fact these patients may be having an inferior myocardial infarction, and I have seen that in real practice, and that's why I'm bringing it up. Then we need to identify the pathway that is most likely to benefit the patient the most in a timely manner. So let me emphasize every word here in this sentence. A pathway that will help the patient in improving the left ventricular function, preserving the myocardium in a timely fashion. Then we have the non-cardiac causes of chest pain, like aortic dissection, pulmonary embolus, pleurisy, or pericarditis, or even like gallbladder attack. All these things need to be taken into consideration. Then structured risk assessment should be used. So we have to have some kind of a risk assessment, especially when we are dealing with a STEMI. It is clear cut what we need to do. When you are dealing with an acute coronary syndrome with ongoing chest pain and fleeting EKG changes, we know what to do. But in patients who are borderline, or people who have, say, chest pain and who have normal examination and even normal EKG, what do we do? And that's where the risk assessment of these patients come into play to see what further tests we need to do. Should they be going home or should they be observed in the chest pain unit? So please pay attention to these points, because these are the fundamental blocks upon which management of acute coronary syndrome is based. This is just an expanded version of that. So let's continue with this. Whenever someone comes with a chest pain, whether they have coronary artery disease or not in the past, the most important question we need to answer is, does this patient have coronary artery disease? If this patient has coronary artery disease, does this patient have a significant coronary artery stenosis that is accounting for the chest pain presentation? Or does this patient have a total occlusion of an artery causing an acute myocardial infarction? Is the patient hemodynamically stable? So these are some of the basic questions we have to answer, because this is what is going to determine about the patient's outcome, preservation of myocardial function, and longevity of these patients. So let us focus on what needs to be established first. And this should help you to triage your patients based upon their presentation and based upon their risk factors and based upon the laboratory studies like high sensitivity troponin, fleeting EKG changes, or hemodynamic instability. Okay, here some description about the chest pain, which most of you are familiar with. I am not going to, say a whole lot about this, because you must be very familiar with, how to differentiate cardiac chest pain from other types of pain, for example, pericarditis or pleurisy. And it is important to also assess, in the short, brief history and examination, the other risk factors like hypertension, diabetes, obesity, hyperlipidemia, history of coronary artery disease, history of hypertrophic cardiomyopathy, or any other vascular diseases like peripheral arterial disease. These things need to be added into the picture to come up with a composite evaluation of this patient. Let us remember that we are evaluating the whole patient, not just chest pain. Nobody comes with just chest pain because they have associated medical conditions which may compound their presentation and their risk. On physical examination, I think you're all familiar what needs to be done. You look at the vital signs, oxygen saturation, lungs for any evidence of RALs or fluid overload, jugular venous distension, heart for new murmurs or for rub, abdomen for any evidence of enlargement of liver, extremities edema, and more importantly, we need to look at the peripheral arterial system. And when it comes to interventions, it has been shown that an approach through the arm or the radial artery has the best outcomes, overall outcomes in patients with STEMI. Again, I'm going to emphasize this fact because on two extremes, where a 22-year-old person comes with some chest pain after he had an argument with his girlfriend, that's a total different story from the other end of the spectrum when someone comes with relentless chest pain for 2 hours, sweating, dizziness, and shortness of breath, and has an acute STEMI. But it is the intermediate group which is most challenging, especially the ones which I'm going to be focusing upon, and that's where all these risk factors come into play. How do we determine whether this is a low risk patient, intermediate risk patient, or high risk patients? I talked about the multiple risk factors that can increase the risk of coronary artery disease. Another test which need to be considered is if they had a coronary artery calcium score, which can be done as an outpatient, does not involve any contrast, and that may be of great significance. If somebody had a coronary artery score, calcium score of 0, the chances of them having cardiac event is considerably less compared to a person with a calcium score of 400 or maybe over 1,000. So these things really do make a difference. Then if you're dealing with the higher risk patients, then we need to look at how do we diagnose if they have STT changes or T-wave inversions with borderline troponins. How do we determine, do they have significant coronary artery disease? I said significant coronary artery disease. And at the beginning, I said our main goal is to determine, does this patient have coronary artery disease? How significant is a coronary artery disease? And what needs to be done based upon the coronary anatomy? Okay, here are definitions used for a low risk patient with chest pain. Risk like less than 1% of a 30-day MACE events. Somebody with a 0 troponin. Somebody with a 0 troponin 1 or 2 hours after the presentation. And here are certain systems that you can use: Halt pathway, ED, ACS, ADAPT. Any one of these you use. You just have to pause this and look at this and determine, are we dealing with a patient with a low risk? If that person falls into this category, these patients can be observed in the emergency room, and if everything comes out normal EKG, normal troponin, the chances of them having an acute coronary event is exceedingly low. Then we need to look for other causes of chest pain. Remember, now a lot of times we say, oh, your chest pain is not heart, you can go home. No, that's not it. You need to make sure that we rule out other causes of chest pain and then decide what needs to be done. Okay, in low risk patients, there are certain other things that can be done, like if you have a chest pain unit, these patients can be, these patients can undergo coronary artery calcium score, or if they are intermediate risk, they could also have a coronary CTA. Or we also can consider a stress testing, like in a chest pain unit, you observe them. If they are of intermediate risk and the EKG and the enzymes are normal, they could have a nuclear stress test before they leave. So these are some of the things. It helps us to, one, risk stratify these patients, and number two, the clinical pathway for these patients based upon their risk, based upon their presentation, and based upon their laboratory tests and EKGs. And here is the different mechanisms by which we can do an stress test, which can be a regular treadmill exercise test if the patient is capable of reaching at least 85% of the predicted maximum heart rate. That I want to underscore that it is very hard for patients to reach 85% of the predicted maximum heart rate, especially if they are obese, if they have arthritis, or if they have other medical conditions that prevent them from reaching the appropriate heart rate. And also a regular stress test may be unreliable, or we may have a high degree of false positive results in female patients. So combining with some kind of imaging modality may be the best pathway for determining. And of course, a PET MPI is probably one of the best ones in not only looking at the location of the myocardial ischemia, the degree of myocardial ischemia, but also looking at quantitative blood flow in various branches of the coronary arteries, and this is something you would reserve for someone with an intermediate risk or a high intermediate risk, so that you are not only diagnosing the presence or absence of coronary artery disease, you can also determine the degree of coronary artery disease and the location of the coronary artery disease. So it serves as a roadmap for any intervention you may consider. And of course, LV function is an important thing which can be assessed using echo, nuclear, or PET. And here are some of the contraindications for imaging, and you just have to read that article and get familiar with this, because anytime you schedule a patient for a stress test, you have to go through this list and see, is there a contraindication for doing a particular type of stress test. And we always need to be considering non-cardiac chest pain, especially if the EKGs are normal, the troponins are normal, and the patient is a low-risk patient, or even an intermediate risk patient. We should think about the major ones like pulmonary embolus, aortic dissection, which is exceedingly rare, but even hyperventilation, anxiety syndrome, or carbon monoxide poisoning, and sickle cell crisis. Some of these things we need to keep in mind, or even like a acute abdominal process that may mimic myocardial ischemic pain. So in a chest pain patient, basically we do the history and physical examination. If you're dealing with a STEMI, we know we follow the STEMI guidelines. Diffuse STT changes consistent with pericarditis. These patients are managed with anti-inflammatory agents. When we have ST depression and T wave changes, then we need to follow the ACS guidelines. If non-diagnostic or normal EKG, I will tell you what we need to do. That's what I'm going to be. That's why I'm calling this as special circumstances. And arrhythmias, we may have patients with chest pain who may have arrhythmias, but it is very rare for them to present with just arrhythmias. But I have seen patients with chronic atrial fibrillation whose heart rate rapidly goes up. They come to the emergency room, and when you do routine lab tests like troponin, they are elevated, and you follow the troponins and you see a serial change in the troponin levels. So arrhythmia is something we need to keep in consideration, especially, as I said, in older patients with multiple cardiac problems who have atrial fibrillation. Every time the heart rate goes up, it increases myocardial oxygen demand that can present as arrhythmia, but it may in fact be related to ischemia. That's why in patients with atrial fibrillation, before they are going for any kind of electrical intervention, we need to rule out myocardial ischemia as a cause of their changes in the atrial fibrillation pattern. Anyway, so patients with chest pain, and we have an EKG, obvious non-cardiac causes, no cardiac testing required. Obvious non-ischemic cardiac cause, then we go for cardiac testing. If it's an acute coronary syndrome with elevated troponin levels, then we depending upon the risk. If it's a low risk obtained troponin, then you use the risk stratification, which I've been talking about. Then depending on the risk, they say if it's low risk, they can be discharged and followed as an outpatient, and other tests done as an outpatient. If it's an intermediate risk, they are admitted to the chest pain unit and followed. And if they are a high risk, then obviously they need to go for invasive angiography. This is an important thing I want to stress, that just because they don't have a STEMI doesn't mean that we can just sit and wait for several days. If somebody has acute coronary syndrome, ongoing chest pain, hemodynamic instability, borderline EKG changes, it is time to consider cardiac catheterization to rule out significant coronary artery stenosis. When we are talking about STEMI, we have very limited time. We have to make very quick clinical judgment that this patient in fact is having a STEMI, but at the same time we need to be considering other non-cardiac causes like acute aortic syndrome. pulmonary embolus, acute myocarditis, or even valvular heart disease. Because aortic dissection can present as an acute myocardial infarction because of the dissection extending into the aortic root, causing coronary blood flow impairment. So that is something we need to keep in mind. I have seen that one or two cases, but it is extremely rare. But nonetheless, if there's aortic root dilatation, and if there's any evidence of then an echocardiography, maybe the initial study to show if there is evidence of aortic dissection. Then obviously we have to follow more definitive tests like CT angiography. Okay, so when we are dealing with an acute myocardial infarction, someone presenting within 12 hours of chest pain and is having EKG changes, having enzyme elevations, then it is clear cut they need to be going through the STEMI protocol. But again, when it comes to STEMI protocol, it depends upon whether the facility has capability of performing PCIs, or whether you're at an institution where no PCI is available. And it depends upon how far your institution is from a PCI facility. Can the patient be transferred and get a PCI within 90 minutes from the onset of chest pain or presentation to the primary hospital emergency department? So these are things we need to keep in mind. Again, hemodynamic stability or instability plays a significant role on how briskly we need to take actions in patients with STEMI or even with just acute coronary syndrome. The other thing is culprit vessel versus total PCI. Should you do the culprit vessel good in 30 minutes, you got the flow established, you are happy, and the patient is feeling better, and you're tempted. There is a circumflexulation or a proximal RCA relation, you can just go and slip in a stent, but is this necessary in an acute situation? And most of the studies suggest that performing PCI of the culprit vessel is the appropriate way, unless there is a need for like a bypass surgery, in which case they should be going for a bypass surgery. Culprit vessel versus total PCI. So here are some important points to keep in mind. If the patient had ischemic symptoms for less than 12 hours, or if the patient is hemodynamically unstable, or if they have ongoing ischemia with chest pain and EKG changes, and these are all class 1 and class 2A indications for coronary intervention. Routine atherectomy is not recommended. That is something you have to keep in mind. That is a negative point, and that may be asked in cardiology boards. The aim is to open the artery in less than 90 minutes from the time of presentation to the emergency department, or from the time of onset of chest pain, if you can time it properly. Then primary PCI, this is the European Society of Cardiology guidelines. Preloading patients with P2 Y12 inhibitor, no benefit with upstream GP2B3A inhibitors. So they routinely recommend preloading these patients with the P2 Y12 inhibitor, and of course radial artery is the preferred method for patients with STEMI, and I will show you a slide in a couple of minutes which clearly shows superiority. Heparin as an anticoagulation and drug-eluting stent is the standard of care, unless there's a compelling reason to use a bare metal stent because somebody has to go for an urgent surgery within the first 3 months after the stent placement. Routine atherectomy is not indicated. It is class 3. That means this is negative answer, and keep that in mind. And short hospital stay. And some of these patients often don't need ICU care, according to the European guidance. And here is a study which showed radial versus femoral artery in STEMI. there was 45% reduction in all-cause mortality, 36% reduction in MACE events, and access site bleeding was reduced by 65% and major bleeding by 49%. So clearly there is no doubt going through the radial approach will significantly reduce morbidity and mortality in patients with the STEMI. STEMI non-PCI facility, and here are some of the important take-home points when you're dealing with a patient with an ongoing chest pain, or you're dealing with a patient who is stable. A non-PCI facility, what do you do? The main question to answer is, can we get this patient from the presentation to the primary emergency room to a place where there is PCI facility available in less than 90 minutes where they can open up the artery? If that is the case, then these patients need to be hemodynamically stabilized and immediately transferred directly to the PCI facility cath lab. If we cannot get these patients in, let's say that person is like 2 hours from your location and you're talking another 30 minutes from that 2 hours before they can open up the artery, then a full dose fibrinolytic drugs and transfer patient to PCI facility for further evaluation and management. And keep in mind, while we are talking about these drugs and procedures, we should always be cognizant of the patient's hemodynamic stability, and that's an important thing which needs to be taken into consideration even during transport. This is called the pharmacoinvasive strategy by the European Society of Cardiology, and STEMI at a non-PCI hospital. First medical contact to primary PCI is greater than 120 minutes. Full dose fibrinolytics, heparin, clopidogrel, and routine PCI if they can be stabilized. If they are unstable, obviously they need to go for further evaluation by coronary angiography and any intervention that needs to be done. And here are several different studies which talk about the safety of primary PCI. Now let's talk about acute coronary syndrome, non-specific chest pain, normal EKG, non-specific chest pain, borderline EKG, borderline high sensitivity troponin, and comorbid conditions. Again, we talked about this risk factor management. You need to assess the risk. Then what do you do when someone presents with chest pain, hypertension, obesity, smoking, and a normal electrocardiogram? And troponin baseline is normal. What do? Do you say, oh, you don't have a cardiac problem? No, I think we still need to be concerned about coronary artery disease because of the chest pain description, because of associated conditions which increase the patient's risk to intermediate or even high because of the age and multiple comorbid conditions. So we cannot just rule out coronary artery disease just based on a normal electrocardiogram. In these patients, here are some of the important points to keep in mind. The associated risk factors, which I already stressed about. Repeat EKG serially and see if you see any fleeting changes. We need to look for extended leads, like looking for posterior myocardial infarction or right ventricular infarction. And of course, the troponin repeated at 2 hours, 3 hours, and 6 hours. And if there is a serial increase in the troponin levels, that is an indicator of myocardial ischemia and injury, myocardial injury, and that is something important even if the EKG is normal. Of course, these patients need to be observed in the chest pain unit, and any further testing decided on the lab tests and the other factors we talked about. What do we do with elevated troponins? We see patients with chronic heart failure or patients with chronic kidney disease. They always have elevated baseline troponin levels. What are we going to do with these patients? if the troponin is elevated, I think the ideal thing is if we don't have a STEMI that we can clearly identify, then we need to follow up troponin at 2 hours and 3 hour intervals. If there is a delta or a change or an increase in the troponin levels, then it is suggestive of acute myocardial injury. If there is no significant rise in the troponin levels from the elevated baseline, then we are not dealing with acute myocardial injury. And if there is no change, of course, we are dealing with a chronic elevated troponin level, and it may not suggest myocardial ischemia. This was taken from the Mayo Clinic presentation on acute coronary syndrome. And if someone is unstable, even if they are having NSTEMI, and they need to be considered for urgent angiography. Early versus delayed angiography, these 2 studies which showed benefit with early intervention. And as I said, if the patients are unstable, then they need to go for angiography. If the patients are very stable, which is not the usual case, then we can wait and see. No benefit to cooling off, no early hazard. So if you're in doubt, go for coronary angiography, establish the diagnosis, and then decide what needs to be done. So the key points as far as pharmacoinvasive strategy. This is for patients at a primary care hospital which doesn't have PCI services. Consider at a non-PCI hospital if there's a delay of more than 120 minutes. If so, you start these patients on aspirin, clopidogrel, and fibrinolytic agents, and they can have routine coronary angiography from 3 to 24 hours for possible coronary intervention. And here are some of the protocols which basically, it talks about the patients with the chest pain and the patients with chest pain suspected of acute coronary syndrome. This is a general approach. Then here we have algorithms for patients with no known coronary artery disease. And this is something we really have to memorize or sort of get familiar with this. I am not going to go through every step of the way, but I want to tell you the coronary CTA is another test that has been added on along with the coronary artery calcium in very low risk patients to triage these patients as to what needs to be done. If these patients presents with no known coronary artery disease, we need to establish, do they have coronary artery disease? How significant is the coronary artery disease, and how do we determine? All of this I have covered. This is just a flowchart from this update, 2021 update, which I talked about, and you can look at this. The main highlighted ones I want to talk about are invasive coronary angiography, which is class 1 indication. Class 2A is the coronary CT angiography. Then we can do a stress testing like PET CT, which can also give us the fractional flow reserve, which may or may not be available in every institution, but if it's available, it helps us to triage as to what we need to do. If they have significant reduction in the blood flow to a certain region of the myocardium, then obviously they go for invasive cardiology. Here, if there was no prior testing, we can do we are talking about intermediate risk with no known coronary artery disease. We can do a stress test, stress echo, or PET, and based on that, or even coronary CTA, based on that we determine what needs to be done. The PET CT is becoming more and more available in many institutions, where we can not only determine if there is myocardial ischemia, where is the myocardial ischemia, what is the degree of myocardial ischemia, what is the left ventricular function, and what is the regional coronary blood flow. And all of this can be obtained from a PET CT, a nuclear PET CT, and that will help us to triage these patients as to whether they go for angiography or go for guideline directed medical therapy. This is for patients with known coronary artery disease. And as I said, please download this article and go through these protocols, because they are self-explanatory. And so when you have a patient with coronary artery disease who presents with chest pain, this is what we need to determine. Does this patient have significant coronary stenosis or progression of a stenosis that is causing ischemic chest pain? And that's our main objective, is to find out, have they got progression of disease that is causing the chest pain that is related to myocardial ischemia. And that can be determined by these tests like coronary CTA or any type of stress testing modality with imaging, I'm talking. And then if we can do like a CT nuclear scan, we can even measure fractional flow reserve and determine what needs to be done. And this is just an expansion of this. If they had no prior testing, which was from the original chart, and this is just an expanded version of that one. So what if someone comes up with all these tests and everything turns out to be normal? Or you do a coronary angiography and the anatomy is normal, or CCTA with no evidence of stenosis or plaques. What is the warranty period? According to this article, the warranty period is only 2 years, whereas if a person had a normal stress test, the warranty period lasts for only 1 year. So let's keep those things in mind. So ladies and gentlemen, this has been a presentation of ACC special considerations in patients with normal EKGs, ongoing chest pain, or non-PCI facility dealing with STEMI patients. I am Dr. Nik Nikam. If you want to get a copy of this 250 pages PDF book, you can just send an email to Dr. Nik Nikam, drniknikam@gmail.com, and I'll be happy to send you a copy of this book. You can look up my email address in the description. And thank you so much for watching this presentation. Please do subscribe to our YouTube channel. I will see you in the next presentation. Thank you.